Good afternoon. Welcome to you, fortunate few. My name is Melady. I'm from the University of Toronto. This is AGEM Gracefully, Innovations to Improve Geriatric Outcomes. We have Dr. Neha Raukar to thank for this, who pulled it all together. I'm informed we're supposed to refer to her as Miss Majesty, as her children do. It's going to be a quick stroll, nay, perhaps a sprint through three core topics in geriatric emergency medicine, and then a very special roundup about how you can make this work at your emergency department. Our speakers in order are going to be Dr. Chris Carpenter from Washington University, then Miss Majesty, otherwise known as Dr. Raukar, from Mayo Clinic, then me, Dawn Melady from the University of Toronto, and finally Dr. Jeff Caterino from the Ohio State University, where he is the chair. The goal is to just review a few core topics in geriatric emergency medicine and how you can make it work. With that, I will turn it over to Chris.
So our objectives are really to paint a picture of what we can do in a positive way to start taking care of our older adults, realizing that there's not a perfect evidence base right now for some of what we're recommending. We don't think that inertia, though, is the correct answer for this population. There has to be some movement forward. There's some promise in the literature, and we're going to try to highlight that, but really point out some pragmatic things that we can be doing today while we're awaiting that better evidence. And we're going to talk about four topics of pertinence to geriatric emergency medicine. So my topic is falls, and I promise to get through this in just a couple minutes without rushing. I only have 3 slides, but we all know fall patients are difficult in most of our EDs to manage. There's the fact that we've got to deal with their acute injury, what may have happened that brought them to the ED as a sequelae of their fall. We have to sometimes convince them that they are a high fall risk and might require some additional attention once they leave our emergency department, and a lot of my older adults just don't see that. They look in the mirror and they don't see the 80-year-old that I'm looking at. They see themselves at 20, and they don't really see that they're going to need any special attention if they don't have a broken bone. And then once we get over that hump and convince the patient that maybe you've fallen 3 times this week, maybe this is something we need to address, even if you're not admitted to the hospital, we have to convince family. And then sometimes we also have to have a resource to refer them to. This isn't happening in most primary care offices in my setting in St. Louis, doing some sort of formal fall evaluation. Most of us don't have a falls clinic to refer these patients to, and that's disappointing because there's 332,000 deaths per year due to falls in older adults. You think there'd be a plethora of research like we see in stroke and cardiac care for falls, but there really isn't. And the falls research that's out there, like the STRIDE trial, that was a PCORI trial funded with $14 million, did not show a benefit in reducing fall injuries. So it's a difficult nut to crack. Some of the things that we think we can be done in the ED setting today are to identify falls as a transdisciplinary opportunity to prevent injury. By transdisciplinary, I mean this is not just an ED issue. This cannot be solved just in the emergency department. We need the help of our primary care physicians, our physiotherapists, home health nurses, in some cases perhaps trauma surgery, but start to build those teams within your sites. Identifying a local champion is really helpful. That champion can be in emergency medicine, can be in geriatrics, it could even be in nursing or physical therapy, but having that local champion within your hospital is going to help to catalyze some change. Look around your hospital and your healthcare system and see what kind of resources you have to deal with falls. I've been surprised in some healthcare settings, they've got some pretty rich resources that the ED just wasn't aware of. And then consider falls a geriatric syndrome, and probably falls aren't the only issue for this patient. Things like frailty, occult dementia, polypharmacy, there's some other issues probably lingering underneath the water there. And then most practically, we put this together a few years ago with my Australian colleagues. Here's a time frame of what you can be doing in the emergency department. The initial assessment, obviously, what caused the fall. Let's look for a medical or surgical precipitant. What are the acute injuries that may be a sequelae of the fall? Within 3 to 4 hours, we recommend, probably we'll still in the ED, some sort of cognitive assessment, a gait and balance assessment to make sure they're not going to fall again in the emergency department. If we're going to send them home, do some sort of discharge risk stratification, so at least the highest subset of recurrent falls are going to be referred somewhere appropriate. And then within 24 to 48 hours, for those that are admitted to the hospital, Make sure we're doing bladder and bowel assessments, assessing for functional decline, because sitting in that hospital bed each day is going to be muscle wasting for the older adult. Get them up early if we can. If we're going to send them home from the hospital or the ED, let's do a home safety assessment. Most of us have home nursing that can check out the home situation and then assess for things like depression, visual impairment, and assess their medications for fall risk-inducing medications. So that's a rapid tour through falls, but hopefully it gives you some ideas.
With 11 seconds to go.
Awesome. And I wasn't talking.
I'm going to talk about medication, so we're going to pivot for a second here. So in medical school, we were always taught that children are not little adults and that we should be looking at them as a separate population. I would posit that actually the geriatric people are not older adults, right? They have many physiologic changes that make them different. They have decreased clearance of medications. They take more medications. They have more chronic conditions. With each chronic condition comes their own list of medications. Chris mentioned the word polypharmacy. That means somebody who's on more than 4 medications. That's almost everybody I know over the age of 65, right? And so with each medication comes their list of side effects and then the management of those side effects. And then we have to think about the practical considerations when you have an older population. They have poor compliance, so when you're in the emergency department, you want to think about using medications that are only used once or twice a day as opposed to 4 or 5 times a day. It's easy for them to make a mistake, even with their little pill boxes that their family hopefully fills for them once a week. It's still very easy to make mistakes, and then you'll see that many older adults are choosing which medications to take because they're living on a fixed income. And so they decide on their own, maybe I'll just take this medication, I'll ration out this medication. And so these drug expenses also add up. So it's a reason to start thinking about medications in a new way. And so we have heard this before, no risk factor for falls or really anything is as potentially preventable or reversible as medications. And so this should help us to start thinking about what we can do. Oh, this was supposed to be an animated slide. Oh, well. So think about medications in the emergency department in 2 ways. Think about de-prescribing what you see the people are taking, and think about what you are prescribing to them, right? So the easier one is to think about, okay, this person has a urinary tract infection. Do I really want to give them a fluoroquinolone, or can I give them something else so I'm not going to put them at risk for fall or any other issue? De-prescribing is harder. In the inpatient and outpatient world, the ED lives in this gray zone, right? But in the inpatient and outpatient world, they have all these lists that they can look at that they can say, you know, we should be de-prescribing this and not giving this, and maybe we need to reduce this. In the ED, it's really not practical to take these long lists and look at them and say, okay, I'm going to withdraw this, I'm going to withdraw this. And in fact, there are studies that have shown that when we try de-prescribing from the emergency department, primary care doctors just put the medications back on anyway, often, or because we had not gone through the rigor of, am I going to really de-prescribe this antihypertensive? What else have they tried? We don't have the time or the information to do that. But there are trials that show that if we are very cognizant and very methodical about how we prescribe medications, we can actually reduce one's fall risk. Gap Care was a great study done at Brown that showed that you can actually do physical therapy and have a pharmacist review medications in the emergency department, and it is practically possible to do that. So when I talk about all of these medications that patients take, you should realize that 20%, almost 20% of the patients that present to the emergency department who are geriatric, their chief complaint is actually an adverse drug reaction to what they're on. So, right, we all hate weak and dizzy. We all hate that. But often they're weak and dizzy because of the medication they're on, or they're vomiting, or they're nauseous. And then what do? We prescribe Zofran, and we prescribe more medications to treat the adverse effects that they're having. And so we really need to take a more thoughtful approach. And if you have a pharmacist in the ED, engage the ED pharmacist to start thinking about what we can do about this. So I'll leave you with a few pearls. Consider a drug reaction when you approach the elderly patient. Is their vague complaint actually a manifestation of their medication? Watch what you prescribe and try to be thoughtful about what you give, and please take advantage of the pharmacist because they know this a lot better than we do.
Finally, delirium. I do need to say that I'm actually here replacing Kevin Bice, who many of you know, and many of these slides were prepared by our colleague, Dr. Maura Kennedy at Mass General. So thanks to both of them. So this is going to be a quick walk through delirium. And since I recognize almost every face in this room, I know that all of you know most of this stuff already. I think a key message that we need to give all of our colleagues, the people who aren't in this room, are that about 10% of all older, and this is one of the things is well evidence-based, about 10% of all older people in an emergency department at any given time have delirium. And emergency physicians are really super, super good at identifying delirium 1/3 of the time. And when we do, we're accurate, but it's the other 66% of that 10% that we completely miss. And the main teaching point that I think you need to pass on to your colleagues is that we don't want to be discharging them home. So main risk groups, and really probably number 2 should be number 1, that is cognitive impairment. So anybody with an underlying dementia or other form of cognitive impairment are the people who are most likely to get delirium and are the most difficult to determine it in because they already are not quite right, and so it's harder to see when they're less right. And the other things I won't go into. I won't belabor this either, but I think we can all imagine that given that delirium is almost always or is always a symptom of a serious condition, either medical or pharmacological, not identifying a serious condition is one of those things that emergency doctors don't like to do. We like to identify serious conditions, and we're being presented with the symptoms, so we need to identify it. I think this is the main teaching point that I'd urge you to pass on to your colleagues back home. We think we're quite good at identifying delirium because everybody can notice when somebody's yelling really loudly and punching you in the face. That's easy to see. That's the hyperactive delirium. Well, the message we need to pass on is that in older people with delirium, very few of them have hyperactive delirium. This is a fact we all know and a fact that almost none of our colleagues have integrated. Most older people with delirium are sleepy, drowsy, withdrawn, psychoactive, psychomotor, retarded, slowed down, the little old lady in no apparent distress, sleeping through the assessment. It's not normal for anybody to fall asleep when a doctor is talking to you, except in this situation where most of you are. But otherwise, if your patient is not engaged with you, that person probably has delirium. Alistair McCulloch said a few weeks ago on a webinar, if somebody is asleep in an emergency department, they have delirium. So we'll just review a couple of these screening tools, most of which are familiar to you. The confusion assessment method, which is the gold standard from long ago, developed by Sharon Inouye, and then all the multiple derivatives of it, the CAM-ICU, the BCAM, and I'm pleased to hear, for example, at Mayo that you've instituted the delirium triage screen plus the BCAM, and then one that is not much explored or used in North America, which is the 4AT, which is kind of the standard around the rest of the world. We need to be screening in a standardized fashion using something and building that into the processes in our emergency department. And I'm sure it was Chris who inserted the last bullet point in here, research questions that we need to be developing around delirium are listed there. So our special guest is not going to be talking about a clinical topic. I'm handing you over to Dr. Jeff Caterino, who, as all of you know, is a chair of a large hospital, a large university emergency department. And what our ask of him is, how do we convince our leadership, him, that these are important things to be doing?
Great. Hey, thanks, Don, and very happy to be here. So really what I wanted to talk about is we have geriatric EDs, we have certification processes, we have some options to do that can improve care, but at the same time, that requires resources and time, and functionally, it requires money, right? So how do we get money to do this? And really, the approach I think that you should take is you have to think like a chair, right? You have to think like a health system administrator. So have 2 stiff drinks and then start answering these questions. So the first is, do we want to do this, right? We have to justify why we're doing it. This room may know why they want to do it, but you need to justify to people, you need to justify in their language, and we'll talk about that in a second, and then how are we going to fund it? And again, you have to talk with the language of funding and figure out where sustainable funds are going to come from. So these are things to consider when you're deciding on if we want to do this. What's important to your institution, right? We've got 4 different boxes here. Who are their stakeholders and what's important to them? The hospital CEO cares about national metrics. They care about, what does the newspaper in town look like? They care about hospital volumes and the whole hospital bottom line. The head of quality for your institution cares about falls and things like that. So you have to tailor the approach, and you can answer these questions pretty much. If you answer all these questions, you're pretty much going to cover the people that make the decisions, right? Just saying it's going to improve patient care doesn't do a heck of a lot. But if you start talking about decreasing admissions and decreasing observation stays, that makes sense. If you start talking about driving your market share, or if you have an ACO where the institution gets dinged for the amount of money they spend per patient, and you can prevent readmissions, suddenly the head of the ACO is a huge ally, and they see this as a benefit. So you need to start thinking about all the different interactions and ways these things, can justify why you want to do it. And so the pitch varies based on different stakeholders, but really can be very effective. If you keep these geriatric patients and older adults out of the emergency department and they don't come in with their fall and their head bleed, all of a sudden you're spending half as much money on them, and the ACO hits some metrics and gets a $5 million bonus from Medicare or something like that, right? So that's important to somebody. If you think about it, those of you who've been around long enough remember we fixed UTIs, right? Suddenly hospitals were getting dinged for catheter-associated UTIs. Giant programs, nursing, everybody's looking over it. There's quality metrics around it. It's the biggest thing ever because it was a nationally reported thing, and for the quality people, and the hospitals is going to lose money for the money people, right? So you find those. You have to find those sorts of inroads and explain it in that language. And it's not just the chair, because the chair a lot of times doesn't have all the funding. The chair has to find the funding from somewhere else. So you have to help the chair make that case. So then what are ways you can fund it? Well, there's a whole different ways, different amounts of ways that money flows into departments, right? So obviously clinical revenue, and some of this is not readily apparent. So for example, physical therapy can bill when they do a physical therapy evaluation in the ED. We actually staff at Ohio State a full-time physical therapist in the emergency department during business hours. They see enough people between our ED and observation unit to justify the cost, right? So billing geriatrics consults, they can bill those, right? So understanding that. The second thing obviously is that you can get some research funding or philanthropy. But then, there's the health system, right? So again, if we keep certain patients out and the hospital system meets the metrics, they've got better funding, and they can divert some of that to us. We've even found times where if the low acuity patients are not taking up hospital beds and they could put a cardiac patient in that bed instead, their net profit, they have a net profit from this program. So generating a true business plan where you look at all the inputs and outputs and estimate the downstream effects can actually make something that looks unprofitable in the department profitable to the health system as a whole. And so you have to think about this as a system, not as just how does the emergency department do this. And I think I should probably stop there. The other thing I'll mention is sometimes state and local funding. There are grants and things like that you can get to start these programs. Medicaid has some things, et cetera. So, all right, that's what I got.
Thank you. So we do have just a few last minutes for questions for any of us, or particularly for Jeff, because while you get to talk to plain old clinicians every day of the week, you don't often get to the ear of a chair so easily.
The people from my department, they're always bugging me, so I don't know what that's
my colleague Jacques Lee from Mount Sinai, Toronto.
Thanks so much. That last point, the global thinking, this is a thing I come across all the time, that the people who need to spend the money aren't the people who save the money. So how do you negotiate that, right? Because they often think of it as my pot, I don't care what's the overall. What are your strategies for that?
Yeah, I think you go up high enough. At some point, all the pots come together under somebody. And so if you get out high enough up to where the pots are all one, right, that is, I think, the first thing. And you do have to have a little bit of forward thinking in the institutional leadership to understand that, hey, this costs $300,000 in the department to do this, but it saves $1 million over here. We generate more, so I'm okay transferring 300 and I'm still ahead, right? So it's being a little sophisticated in the business plan, but also getting, if you just talk to the person who has a different pot than you, they don't want to give up any of theirs either, right? So you just got to get above them and come down.
So just on that note, the article by Yula Huang, which appeared in JAMA Network last year, that opened, demonstrating the significant saving to the system by a geriatric nurse or social worker touching an emergency department patient. The criticism of that paper was that, well, that saves the system all that money, but it doesn't save the emergency department all that money. That actually is an argument that is not true almost anywhere in the world except in the United States, right? Because in almost all countries of the world, there's some kind of a managed system where system savings are important to everybody, because when the hospital saves a whole bunch of money, that benefits everybody. And Chris has...
In the Canadian healthcare system, then, if the system saves money, do they give that difference back to the emergency department?
It's not so direct as that, but I think there is a perception... No, not, well, that's not true, because we do have a significant pay for results program within the Ministry of Health in Ontario, for example, where if you meet certain targets, you do get more money. So keeping 90% of your time to physician initial assessment below 2 hours, you do get more money for that. But it isn't, it isn't, if you do good and you always get more money, as your mom probably taught you long ago. But I think there is, in most systems of the world, there is this kind of collective thing that saving money within the system is kind of good for everybody, and it will eventually come around. So, any other questions?
And if you want to do something measurable, right? So in a setting like that, I would say, look, if you give me a geriatric nurse practitioner who's going to cost $500,000 a year to staff, I think we can prevent 120 admissions, and that's going to save the system X amount of dollars, right? So you get something, you go to them with a measurable metric, and they know exactly how much money they make or lose on every single inpatient, based on, they know this, right? So I can give you this, this, and this, and at the end of a year, we'll see what the metrics show, and I think you're going to be ahead $500,000. And so it's kind of it's a bit of a sophisticated negotiation, but you can get them there if you meet them on their terms, rather than just saying, hey, I need $300,000 for a geriatric NP program, right? They're going to say no.
And I think this is a key message for this whole session, is because we're all of us here are kind of interested clinically in older people and in education. None of us is very good at making all of these financial arguments, but it's where we need to be able to talk to people about making change within our systems. Neha, why don't you say goodbye to us all?
So I'm saying goodbye. So thank you all very much for coming. If you have any questions, feel free to reach out to any of us. We're all very accessible. And I hope you have a wonderful day in New Orleans. Take care.